Thank you, Dr. Linder, and thank you, Dr. Garson, for the invitation as well. We've really assembled a blue ribbon commission here to be our panel tonight, and we're going to be talking about the social determinants of health. We're going to talk about how they relate to healthcare. So let me give a brief introduction to our panel. So sitting right here is Judy McFarlane. She is the Parry Chair of Health Promotion and Disease Prevention at Texas Women's University College of Nursing. She conducts research on domestic and international domestic violence, and she does that both domestically and in the international sphere. And Dr. McFarlane is the technical advisor on a 5-year randomized controlled trial in Pakistan funded by the Bill and Melinda Gates Foundation to test economic skill building as an intervention to prevent abuse of women. So she is really one of the foremost experts. And just as a personal note, when we moved to Texas 13 years ago, the first person that we made an appointment to see was Dr. McFarlane, because we could not believe we were moving to the city where Judy McFarlane was. So, and she was so gracious to us, and she's been a real mentor to both of us. Now, sitting next to Dr. McFarlane is Raquel Roberts. She is the director of the Office of Policy and Planning at Harris County Public Health. So she's a real government leader. So that's exciting to have on the panel. She leads comprehensive community health improvement planning initiatives, also coordinates legislative and regulatory policy efforts. Strategic areas of focus for Raquel include health equity, health systems transformation, and early childhood intervention. She serves on the Texas Medical Center's Government Affairs Advisory Council and the Texas Association of County and City Health Officials Policy and Government Affairs Committee. So we have a real expert in how the government is viewing this. Then next to Raquel is one of my heroes, Linda Highfield. Dr. Highfield is an associate professor in community health practice and the director of the community health practice program at the UT School of Public Health. She's the principal investigator for a 5-year Center for Medicare and Medicaid Services Accountable Health Communities grant, which is really looking at social determinants of health in that Medicare and Medicaid population. Her research includes applied geospatial methods and dissemination and implementation science. So we're going to really figure out what you do when you figure out what to do, how to do it. And then next to Dr. Highfield is Chris Greeley, who is the person I'm trying to be like in my adult life. So Chris is the chief of the section of public health pediatrics at Texas Children's Hospital. He's also a professor and the vice chair for community health in the Department of Pediatrics at Baylor College of Medicine. He is an international expert in child abuse and in social determinants of health. He's the current president of the Ray E. Helfer Society, which is really the honorary society for physicians and healthcare providers who seek to reduce the burden of abuse and neglect among children. And he was on the board of directors for Prevent Child Abuse America from 2005 to 2014, and between 2009 and 2013, he was the chair of that group. And Prevent Child Abuse America is really the organization that over its 40-year history has really raised awareness about child abuse in America. So with that as an introduction, I just want to say to those of us that are listening on the web and on the video, Adele is here, and if you look below the video box there, you can send in email questions, and then Adele will let me know and we'll ask them. And then to the audience that's here, we want to make this interactive. So as we're going through the questions and the panelists are giving their input, you are certainly welcome to put your hand up. Adele has a microphone because we're recording this, so wait till you get the microphone till you speak. But we want your input. We know most of you have worked a very long day, so we're going to end no later than 7 o'clock. So, but we really do want to interact. Okay, so let's start. So we're gonna obviously address social determinants of health today, and the first question is really going to be introductory and preparatory for that discussion. So the question is, what are the social determinants of health, and how do they fit into today's approach to public health and healthcare? And To lead off our discussion, I'm going to turn to Dr. Greeley, who's going to give us a few comments, and then we'll kind of work our way down. And I would like the committee, the advisory, or the panel here to interact as well. So if Chris says something that you just cannot believe, just pipe up and we'll let him speak. So go ahead.
It is so profound. So by way of introduction, social determinants of health is a catch-all for, in essence, the non-medical things that affect people's lives. And we normally would think of that something like water and oxygen and things like that, that aren't things that you go to a doctor's office to give. But really, over the past probably 15 years, that definition has really expanded. And so until about 2005, the publications in the healthcare literature on social determinants of health were quite modest. And then starting mid-2000s, there really was this explosion in exploration of things that affected people's lives that weren't healthcare related. A lot of this was driven internationally by the World Health Organization having a commission on the social determinants of health, which was chaired by Michael Marmot, who was an epidemiologist from the UK. And their framework was, why treat people and then send them back to the place that made them sick? And so the whole idea was, people come to healthcare providers for lots of illnesses, and lots of times the illness are things in their context where they live. And so over the past decade, it has been expanded to things like growing up in poverty, growing up in violence. So not just, oxygen or smog or water quality, but growing up in a context and living in contexts that were hostile to your health, that were related to the health that you had. And a lot of this work has been piloted, at least in my framework, in children. It is the effect of growing up as a child in what the American Academy of Pediatrics has framed as a toxic environment. And that impact of growing up under a violent or neglectful environment has over the lifespan of the child. And that's demonstrated that there are social things, not just environmental, but social things that are meaningful to the life of a person that healthcare usually doesn't address until it manifests as disease. And so over the past decade, 15 years, there has been an increased appreciation that the context in which where people live in may not be overtly hostile, but there may be covertly hostile and affecting the health of that person as a child, as an adolescent, as a young adult, and as an older adult. And that all is the social impact on their lives.
Dr. Highfield, would you like to add to that?
Sure. So I would just add a little bit to that, thinking about kind of the integration of where we are with healthcare and public health from the perspective of social determinants of health. So I think, traditionally that's kind of our domain, that's our realm in public health, is to think about these environments and this broader context that's affecting people's health and their health outcomes. And in the last several years, there's become a real interest in thinking about how do we better integrate or interface these two areas. And so thinking about what that looks like and, kind of where does the data break out. Of course, I'm a data person, so I'm always biased to think about that. And a lot of the recent research, supporting what Chris mentioned, indicates that what's happening in the clinical environment in the healthcare context is only about 10%. About 40% of somebody's health outcomes are being driven by these social determinants of health. About 30% are health behaviors. So really thinking about slices of the pie, about 70% of that is traditional public health domain. And so it's really interesting to think about how we can start to interface these areas. And so thinking about how do you start to cross public health and healthcare, what does that look like? How do we do things like screen for social determinants, intervene on social determinants, and help connect people to resources to address those? So that's an area that I'm particularly interested in, and I'm sure we'll chat more about throughout the course of the panel.
Yes, we will keep coming back to on that. Raquel, would you like to make some comments about what the social determinants of health are from your perspective?
Sure. So I represent one of the large health departments for Harris County, Harris County Public Health. And traditionally in public health, you can think of really a cadre of services that are pretty familiar, like infectious disease control and surveillance and nutrition and environmental health, issues around air quality, water quality, and those kind of things. Public health has had a very long-standing tradition working, providing services in those domains. But more recently, and I would say that this is probably even more so a development in our field in the last maybe 5 years or so, health departments across the nation are really starting to think more upstream about how are we going to better address some of the more fundamental health issues, looking at social determinants of health. So before, we might not have seen ourselves as having a role in early childhood education, perhaps. We might not have seen ourselves as having a role in the attainment of education, whether that's high school or college and beyond. But we're actually starting to look at those things. We might not have seen ourselves as having a role when it comes to housing or the legal aspects of health. But these are things that health departments are looking at very seriously, because it's not until we start to address some of those more upstream challenges that we then will begin to see some changes in health as it pertains to things like obesity or injury or violence and a number of other challenges that health departments and our communities are dealing with on a day-to-day basis.
Okay, great. Dr. McFarlane, can you give us some insights then on both the domestic and the international side of kind of what you've been hearing and what you'd like to contribute?
Oh, I love the World Health Organization definition. The condition in which people are born, is it on a dirt floor in Pakistan where half of the births occur? In which they grow. What is the stunning? Internationally now, we're very concerned about the prevalence of stunning. In Pakistan, stunting has increased from 30% to 45%. And I'm starting international because I want us to always think globally and act locally. And said another way by the World Health Organization, it's the causes of the causes. If a child is stunted and the cause is lack of food, then what is the cause of that lack of food if it's an area of plenty? What is the economic dimension, the economic solvency, the jobs, the language skills? How is the economic profile impacting availability, accessibility of those foodstuffs that half of the children are not stunted at all? So what is the equity or lack of equity of access to interrupt the causes of the causes? Because we work so far downstream with mortality and morbidity that how do we swim upstream? And I hope we can talk about that this evening. How do we be like the salmon and go upstream?
Okay, thank you. So we're going to jump in that pool then, and we're going to talk a little bit more practically. We've heard a lot about the concepts around social determinants of health. Let's talk now about the pro and the con. So the pro would be benefits and possibilities. The con would be limitations and barriers to screening and intervening for social determinants of health and for adverse childhood experiences. So we've heard a lot about what the social determinants of health might be. Clinicians tend to like to screen for things. Public health people tell us to screen for things and then make a referral. So, Chris, can you start us with the pro and the con?
So the pros and the con, the framework is basically screening, referring. And the first pro is, well, that's where the people are. And so there is in the healthcare setting, there often is a healthcare provider and a person. And that is a good location, and it is in a location where the person is expected to be asked private personal questions, because many of the questions that have to be asked are, do you feel safe at home, or something akin to that, or tell me about when's the last time you skipped a meal because you didn't have enough money. Those are not questions that can easily be asked. Or asking a parent about their spouse, is their spouse neglectful or abusive to a child? And so the healthcare setting is, from the pediatric lens, an excellent location because it is a place where a mother, often a mother, and a child will come and be in a room with someone whose job it is to be interested in their outcome and their health. And so often that's a context that doesn't happen anywhere else in society outside perhaps houses of faith. That there's not a place where that kid, from a pediatrician's perspective, and that parent will be with someone who is interested in that question and perhaps is capable of responding to that question. Sometimes they're not. So the screening, the pros, is really that's an access to persons that come to them. Now there's the cons, from my perspective, often is if screening is done and there is a identified social risk factor, the cons often are, well, what do you do about that? And that really is where data and experience and research can help shed light on potential responses, because many times when I was in private practice many, many years ago, I'd ask a family a question and they'd answer my question, and that would terrify me because I didn't know what to do next because they said yes or they said no. And it was sort of challenging as a practitioner. If you open Pandora's box, are you capable of responding, especially if you're asking questions about poverty or violence or transportation or housing? What do I do if they say they're about to be evicted? I don't know what to do. Healthcare historically has not been trained or oriented to respond to that. And that's one of the challenges, is we have to, as we start getting into these social determinants and social drivers, is to be able to say, what is the role of healthcare in the screening, but then what is the role of healthcare in a larger model in responding to those?
Chris, can I just comment?
Please,
Because
please.
you used that expression, opening Pandora's box. So I had the honor of being at the presentation when Dr. Suggs talked about her research. So she did an interview study where she interviewed healthcare providers who were asked to screen, and they had chosen not to. So she asked them, and she used qualitative techniques. And almost to a person, they would say, one of the reasons why I choose not to screen is because it really feels like opening Pandora's box. Because I find out all this really awful stuff and I feel very connected to the patient, but I have nothing to do to help them. So in some ways, I'd rather not open Pandora's box. And as you know from Greek mythology, Pandora's box, when you opened it, all the evil came out. Okay, Dr. Highfield, can you give us a little bit of your view on the pro and con?
Sure. So kind of piggybacking on what Chris mentioned, I think that a couple of the pros of doing screening in the clinical environment are finding the needs. So I take a little bit, I guess, of a different view. Yeah, you might be opening Pandora's box, but right now we know there's unmet need there. We don't know a lot about what it is. We don't know the prevalence of it. And data is power. So from my perspective, from an epidemiological perspective, it's really important to find those needs and to quantify those needs so that we can start to develop interventions that work. So I actually think finding that unmet need is an important component and a potential pro, not just a con. Ideally, if you do find those needs, then we're in an environment where hopefully there's some level of trust already established between the provider and the patient. And that's an opportunity for us. To leverage that trust. A lot of what drives patient behavior is physician recommendation and physician referral. And so being able to leverage that to send patients out to the community where they can access resources that they need is really important, and I think a good opportunity there. So those are a couple of the pros that I think would add on what he already mentioned. On the con side, I think, kind of where we are right now with the state of the field and the state of the science is that we have a lot of screening tools. We have a lot of validated instruments that we know can get at the information we're looking for. We know a lot less about how effective interventions are. So if I screen someone for a social determinant need and they're positive, is it enough for me to refer them to a community agency? Do I need to do a more active intervention than that? And what does that look like? And ultimately, how does that affect healthcare outcomes and cost? We don't have a lot of good data on those parts of the puzzle just yet. And so that's an area that I think is really active and important, right? So you don't want to screen for something that ultimately isn't going to have an impact, right, or have an effect. There's also the potential always to do an unintended harm, which we don't want to do. But if we're screening for topics that are really sensitive, something like interpersonal violence, there's always a potential risk there that we have to be aware of. And then, like he said, of course, if I can't address it, what do I do, right? So I always advocate to people not to screen if we haven't thought about the intervention side and what that might look like.
Okay, thank you. Raquel, as someone who really shoulders a lot of the public health responsibility for this county, how do you think about the pro and the con of screening for social determinants of health?
So I would just echo much of what we've heard up to this point, and that is there really are some concerns about what happens next. So you do screen a positive, what services can be made available to an individual who might need access to food, or might have a housing issue, or might have an issue similar to housing, but as an extension of that, something related to their rights around tenant issues. Sometimes clients, patients deal with challenges that are really beyond their control, housing conditions that are beyond their control, but the landlord may or may not choose to be responsible in ensuring that those conditions are suitable for health. I'm just thinking of families that deal with mold issues and just decrepit conditions that are really outside of their control. So that then introduces the need for, I think, medical legal partnerships, in that health systems are now looking to the legal community to provide some wraparound services around some of these patients. So I kind of jumped into one of the challenges, but on the flip side, I do think in terms of opportunities, it does open doors for collaboration. And so where health systems may not be working as closely with those community-based organizations, it does provide that kind of opportunity. In governmental public health, we see ourselves as a connector in many ways. There are also other groups that very much want to help formulate those linkages. There's local foundations that are really invested in this work to help build those kinds of community clinic linkages. Episcopal Health Foundation comes up as one example. But I think despite the challenges, I think it is important, even if we don't have all the evidence of what works, we do have to position ourselves so that we are responsive to a need, even if we don't have the full picture figured out just yet.
Great, thanks. So, Dr. McFarlane, as someone who over a number of decades has studied screening behavior, and as someone who's an advocate promoting effective screening behavior, can you give us some insights on the pro and con?
Well, once upon a time, 3 decades ago, like you said, over several decades, when I had brown hair. Well, you didn't, but you insinuated more than a couple. I had brown hair, and all brown, and I worked right across the street at Texas Women's University. We were right here in the center, and we've moved now to the Southern Gateway. But we allocated 1 hour of our undergraduate curriculum, 4 years, to abuse. Child abuse, spouse abuse, elder abuse. We really didn't think it happened much. We didn't know what to do about it if it did. Certainly not in families that we knew, God forbid ours. So we spent 1 hour talking about it. Well, be wary of those students on the back row. They're not frequently sleeping. And I had a student ask at the end of the hour, are women abused when they're pregnant? Well, I said, of course they are. Well, how do you know that, Professor? I said, because I'm a volunteer. I was born with a A on my forehead for advocate, turned it upside down to be a volunteer, and I spent most of my life volunteering. And I said, I was at the shelter last night, and there were not one but two abused women. And a very astute student, she said, how often does it occur? I scratched my head. I said, I have no idea, but we have the second largest medical library in the United States, one of the largest countries on the only planet that we know that's inhabited. Let's close the books, put them in your backpacks. We're walking over to the library for the rest of class, and we're going to find out the answer. Where are the articles? Where are the books? Where are the citations on how often women are physically hit, slapped, kicked, punched, physically abused by their partner when they're pregnant? Everybody have the question. 30 years ago, not even 30, about 28 and a half, not 3 decades, 2.5. So we marched over there, and I said, there may be a little reward. We went into teams, and that was when we had card catalogs. You had to get your pencil and your little 3x5 cards out, and everybody wanted to win because, a few extra points in this.
Did you have telephones?
Yes, and you carried them in a box, good sir.
Okay,
and
good,
you were
good.
so proud of that
Good.
box that you carried around in your car with that phone. And so we got over there, and after 2 hours we convened, and we had not located one article, one book, and that's when we had books in a library. And we had not identified any evidence of how often women are abused when they're pregnant. And it's only been 28 years. And I bet many people in this room are older than 28 years. And so they were the product of a pregnancy or have had a pregnancy that many women were abused. We did subsequent studies, and 1 in 6. It was a lead article in Journal of American Medical Association 2 years later. A group worked with myself, and that we interviewed 600 women. And did any of those women say, why are you asking me? And those women were right across the street in 2 hospitals of the Texas Medical Center, and we did not want to have only a hospital base, so half of our sample was from your health department. Thank you very much for cooperating. I knocked at the health department door, and we were in 24 hours. That's when IRB was very different. And we went to private physicians, and it wasn't in their practice, certainly not among the women they were delivering in the hospitals. So certainly it would be a waste of my time to talk to them. So after you go to enough fundraisers and you talk to enough people, you finally found, I found a friend of a friend that owed a friend a favor. And I started in one practice. And the first 3 women I talked to reported abuse. So she said, I think you need to talk to all of my clients. And then she presented. So that's the way that started a 1.5 years later. So what does this have to do with screening? Because we have screened thousands and thousands of women in my lifetime, just with my research, and hundreds of thousands. Never have I had a woman say, why are you asking me that? Thank goodness is usually the response, that you're concerned about something besides my weight on that beam balance scale, thank you, or my urine, or the blood you take. You're concerned about me as a person and my safety. I had women start to cry because I was the person, the nurse that did it, and it frequently, has been a nurse, was the first person to ask her about her safety and not about how many apples she ate or didn't eat. We tend to granulate our profession, people, instead of the holistic, the person. There's a soul, there's a person there. So I think the pro is making not only the woman aware that she's not the only person in the world, but upscaling those prevalence numbers to this is a national problem. This is an international problem. We will never address what we don't acknowledge. So I think that is a huge pro to doing it. Now the con, every woman that's ever been abused that I've ever talked to, and it has been thousands, she asks for the same thing. And if I was in a classroom, and I'd love for us to sit on the floor, sit in a circle, and talk about this informally, they all say the same thing. They don't want you to find a new house for them. They don't want you to find a new life for them. They want you to fix him because they love him. They don't love his behavior, but they love him. He's the only biological father that their children will ever have. So we cannot fix him. He can fix him. So how do we link him into the services? How do we begin that process? And this is where I hand off to you, Dr. G. What is our role to integrate, to interface with what the people want?
Okay. So we will come back to that. But I wrote it down. Oh, there's a question.
No, quick comment.
Comment.
Quick comment. In New Zealand, they wanted to address domestic violence. So they actually put up signs that with rugby players, because rugby players are cool, saying that domestic violence was not cool, was not the way to do it, and how to get help. And they had the hotlines, and they actually had, it raised the issue. It became much more transparent, and more people were calling in to get help. Now, whether the actual incidents decreased, I don't know.
Good. Well, thank you. So that brings up, first of all, those that are watching on the video on the internet, if you have any questions, please type those in, and Adele will forward those to us. But I did want to now turn to the audience. You've heard our panelists talk a lot about the concept of social determinants of health, and now a little bit of the pro and con. So we want some questions. So I think I saw a question here, and then we have one here.
So I was really struck when, Raquel, you were speaking about how health departments are now thinking about things like education and housing, which, as far as I understand the organization of government, have usually had their own departments with their own budgets. And so I'm wondering about, once we acknowledge that social determinants really play a huge role in health outcomes, where does that leave the health department in terms of making budget decisions and collaborating with other departments? I imagine that's quite a challenge.
Yes. So there are, I think the issues are so big and infinite that there will always be a role for public health, even if, and it wouldn't be in competition with the role of the education sector, the transportation sector. But there is a real need to look very carefully at policies that are coming out of each of these sectors. So like MAP 21 is a transportation-related policy that enables safe routes to school, for instance. It's up to public health to be informed and understand that there are a lot of policies, funding in many ways attached to those policies that fall outside of that sector, where the partnerships and the collaboration is really critical. So we don't necessarily see ourselves as, I guess, in competition with the other sectors. It's more of just changing the way that we do our work. So if we're going to be advocating for certain health policies, it's really incumbent upon us to draw connections when we engage our elected officials that this is in fact a transportation policy that we're talking about that has direct impact on health. There's this growing interest in health in all policies, health impact assessments. Our Environmental Public Health Division, for instance, did a health impact assessment in the city of Pasadena and also the Aldine community. And many of you might know in Aldine specifically, there's a district that's being developed where it's like a town center, and they're bringing in all kinds of built environment kind of infrastructure changes to make it more livable, really help drive some economic activity in that area. What then would be the health implications if a new road gets created that on one hand can increase accessibility to and from that district, but what does it create in terms of conditions that make it maybe less safe for children to navigate because there's nearby a nearby school. Those are the kinds of things that health departments are beginning to look at more closely. And so just to inform those kind of decisions and make sure that a health perspective is provided so those decisions are being made, that's where we see health departments really having a role.
Chris, I think you want to add something?
Yeah. So I think that's an excellent question, and to reformat it slightly, A few weeks ago, I was speaking with a number of superintendents of ISDs throughout Houston about education success. And I brought up social determinants of health, and I said, for example, food insecurity. And they said, well, food insecurity is not our domain. And I said, well, respectfully, I'd like to push back and say, your domain is successful education of children. If they didn't have books, it would be your domain. If they don't have nutrition, you may not have the tools to respond, but it is in your domain. And it was reframing the idea of, we may not have the right tools to respond, but that doesn't make it not our problem. And it is then, which we'll get to, the complexity of this, it really does require intimate collaboration between sometimes partners and sometimes not partners. And so whether it's screening for violence, the education system may say, well, that's not my problem because we do education. But if the public health model, if this is a challenge to a child's learning, it does become your problem. You may not have the skills to respond, and you may need to seek other people to help you respond, but it is part of your problem. And it's the same idea with the health department. Transportation, their response isn't, it's not my problem, it's just, okay, now who do I have to go to make this my problem better? And so it is sort of reframing the idea of what is my problem.
So, Dr. Highfield, you do a lot with accountable communities, thinking about a lot of that multi-sector work and how different sectors in our landscape are meant to work together. Can you comment a little bit about the question?
Yeah, I mean, I think that that's obviously a great question, and just piggybacking on what Chris said, an opportunity to think about this as a systems issue, right? And there are these various components of the system that unfortunately end up in silos a lot of the time. And so thinking about taking a step back and thinking about how do we make those connections across the system, right? So we're all working towards a common goal. I think that it's really important to think about collaborations and partnerships and approach it from that kind of perspective. I think that that's really helpful. It's something that we're certainly having to tackle with the Accountable Health Communities project. So just to give you a little bit of background about what we're trying to do there, the project is really focused on systematic screening of Medicare and Medicaid beneficiaries or patients in the clinical environment for social determinants of health. And then if we find a social determinant need, a two-level intervention is being tested. One is a referral to community resources, and then the second level is patient navigation. And the idea there is that you work with a community health worker or a patient navigator to address whatever need has been identified and ensure that that patient connects to a community resource. So obviously, in order to do something like that, we need a lot of people around the table, right? We need our clinical partners like the hospitals, and the outpatient facilities. And we also need a lot of community organizations involved because they're ultimately going to have to address some of those needs. And so it's really been a lot of trying to bring everybody to the table and really come at this from a collaborative perspective and think about what are the strengths and the assets that we already have in the community and how can we leverage those so we're all working towards the same goal. Does that kind of address your question?
And Dr. McFarlane, did you want to comment about any kind of experience you had with multi-sector work?
Well, I do, and I don't want to lose your comment, your hands putting up there, and I don't want you to lose that thought. But I think this is so innovative what Dr. Hightower, and there's a whole collaborate of us, dealing with this issue, and we're looking at not nurses or physicians or public health people moving out to the community when people are identified that are experiencing violence when they come through the emergency department in her study, but we're looking at lay advocates, training the people in and of the community. I live in Montrose, primarily GLBTQ community. I volunteer in my community. I know my community. I know the resources in my community. I know the issues in my community. I go to another community 2 miles away, I'm ignorant. So to be able to use the people, empower the people, and look at different models for changing, interrupting these social determinants. And can we ask our guest who has the hand up.
Well,
Do
we have
please
one
speak.
guest here first, and then we'll get to the next one.
Okay, thank you.
Yes, go ahead.
Hey, what came to mind was limited time constraint for physicians in these screening rooms. So, do you foresee like an order of importance of screening questions being asked? There's the saying the squeaky wheel gets the oil, but there seems to be a lot of squeaky wheels going on, and lots of different public health officials advocating for their cause and their beliefs. So the point about not screening if you don't have a solution resonated in the fact that it seems like you could alienate people and have them lose faith in a system where you just ask me an extremely personal question and you have no resource to do anything about it, and that those are people who needed a resource and didn't get them at the time. But are you working on ways to kind of create a pecking order of what resources we have available and to determine what questions and the linkage between if I ask this question, what prominence should it be given on a screen?
Okay, great. Thank you. And I think, Chris, you want to start off?
That's a wonderful question. I think that I would think of it under two contexts. The first is the screening at the medical office. I intentionally didn't say the physician because my wife is a pediatrician, and whenever I come home, she says, if you make me do one more GD screen, I'm going to kill you. The idea, she doesn't say that, but that's sort of the sentiment. The idea that the physician, you can co-opt that time, that she is the person to do it, I think that's never going to work. That doesn't mean that the office, as a site, a safe haven with medical people and maybe advocates who are part of a system to address the issues that come up, that's the value. It's not my wife as a physician, although she's tremendously smarter than I am. It's not the value of the physician per se that could do the screening. So that's the first thing, is that if we rethink what is the role of the office space and not just that person, that gives you some latitude to think through what is the best way to identify these things in this space. The second is that one of the questions I think we'll get to is that this whole thing is really complicated. So it's not like I screen for intimate partner violence and that's the only thing going on in that woman's life. So to reframe it as you can broadly screen for a whole host of things and check items from box A, that is a yes, and then we'll put you into this package, that the response is screen for these things and we give you an answer. The response is how much at risk and what are the things we can do to help you? I'm not a huge fan of screening for things that you're not going to be able to do much about, but that doesn't mean we can't help her or him. It just is, tell me the kinds of things that are going on in your life. There are certain clearly identified things, food insecurity, violence, poverty, things like that, that we can perhaps hook you up to, but I'm not going to just screen and refer. I'm going to screen and have a system in place to address the complex needs that people's lives have. If someone has a difficulty with transportation, that's not their only problem. And so to say that it's a screen and refer alone without recognizing the complexity of people's lives, I think is a recipe for lack of success. Is that you have to recognize that you're not just screening for this one thing, and I'm going to give you this one thing, because that one thing means the likelihood that there's 2, 3, or 4 other things is much higher. And you have to be prepared for that. So it's complex, and that office can be used as a site, not a specific person.
Okay. We'll come back to this
Yeah.
if that's okay. Now, we have a comment here, a question. And then this will be the last question, then we'll move to the next. Go ahead.
Thank you, Dr. McFarlane, for acknowledging my hand, because my question is for you. So in my agency, we are doing the screenings, but one barrier that we are running into is that sometimes people just don't want to respond to the screening, or they won't turn the screening form back in. So in your experience, what method works best? Face-to-face interviews in the exam room, self-report pen and paper screening forms, and just what have you seen is the best way to get people to actually disclose that something is going on? Because we'll have people that mark, positive for the food and security questions, but then at the bottom of the form mark no, that they don't actually want help. So we're struggling with what's the best way to engage them in this process. I'd like to hear your advice.
The data's mixed. We've done hundreds of studies, and I think it depends on respect. People will tell us what they want us to know when they want us to know it. And I think it's a matter of us, are we willing to give the clients that respect that when she says no, and I've had women say no to violence with bruises on her face, I check no. Because I respect her answer. I'm not going to challenge her. I may be the only person in her world who has ever respected her answer. I think we always begin with people with where they are and giving them that respect, setting that foundation, but asking any of the social determinants questions once is not good enough. They need to be just as important as blood pressure. I would be terribly insulted if I went to a healthcare provider and didn't get my blood pressure checked. Now, I know it's perfectly fine because I check it myself, but it's part of the expectation. So when will social determinants be part of the expected healthcare concern for each client?
So we're going to move on a little bit, but I think really that question really is related to this question, and then we'll circle back to you. So how can the healthcare community appropriately address sensitive issues like intimate partner violence and food insecurity in an effective manner, given the complexity of the situations and the limited time with community members and patients? So Chris, do you want to lead off on that? Because you started there a little bit saying, if you think about not just using one specific discipline, one specific profession, it opens up the opportunity. So first of all, how do you think about dealing with the sensitive issues? And then maybe you could deal a little bit with the format of asking those questions.
Yeah, so the sensitive issues are, I think, again, the data are mixed on the best way to ask sensitive issues, whether it's on pen and paper or computer. But for the most part, it is, as Dr. McFarlane said, in a respectful manner, and specifically when it has to do with violence, one of the things that I've learned from Dr. McFarlane is screening without another person around, so in a private environment, so that she or he, if it's a man, will feel like their information is protected in some way, and that the reactions often would also be well to anticipate, to say, I'm going to give you a screening tool, and this is what's going to happen. I'm going to look at it, no one else will look at it, we'll talk about the answers, so that he or she may be comfortable that they know, because a lot of times just filling it out, you don't know, is the receptionist going to read it? Is it just going to go into my chart? Is my spouse going to get it? And so to be able to anticipate what will happen with that information keeps the control with the patient, that it is still their information and they can control that information. So asking it in a sensitive way, the exact tools, I think, it depends on, there's lots of screening tools, We Care, Prepare, all these different ones. None of them are the best. And that's why I'm really sort of hesitant to say, here's a tool, fill it out, put it into the Scantron, if you remember what Scantrons were, and it'll spit out a number. I think those are not useful because it really sort of depersonalizes it, and it gets back to what Dr. McFarlane said about taking that person seriously where they are, and it's getting that information in a way that they're comfortable that you're going to be sensitive to it.
So can I just comment with that, Chris? It seems to me somewhere in some of our lectures somewhere we talked about screening being reframed as a process, not an episode. So even though you screen, and let's say and you're doing it in a respectful manner, and the person doesn't want to be screened, the actual behavior of screening and alerting that person to these questions in terms of the trans-theoretical model is starting to normalize the fact that it's okay to be asked these questions, and professionals will ask you these questions, and hopefully it kind of creates the awareness that this problem exists. Maybe not just for me, maybe it just isn't my problem. Because if this professional in this office is asking the question, maybe this is something I should be thinking about, and maybe it isn't my failing that I'm in this situation. Maybe it is an issue that I should work with this professional. So I think if we adopt that notion that it's not a failed screen if the person doesn't want to participate in it, but it's a process, and they might eventually get comfortable with you or with someone else who's screening, that this isn't just my problem. Because if they're asking about the question, so like your example, blood pressure must be a problem for somebody, so I'm glad it's not my problem, but clearly it's something that it's okay to be asked. Dr. Highfield, did you want to say anything about the sensitive issue piece, because you clearly are stepping into that?
Yes, I am clearly stepping into that, which is a little bit terrifying. So honestly, the first thing I did was to reach out to my esteemed colleagues and say, what do I do? Because you have a wealth of expertise and experience that I don't have. So I'm an epidemiologist. I am a methods person. So I'm very interested in the widget, right, the tool. How do I deliver it? What mode do I deliver it in? What kind of answers do I get back? But I am not an expert in interpersonal violence. So the first thing we did was engage with our community partners and seek their help and their input on that. So I really would defer to Dr. McFarlane on that. As far as our particular process, we are going to be delivering the instrument in a variety of different modes. We're really interested to see kind of what the response looks like if we deliver it in person, over the phone, on a mobile device, in a kiosk, in the clinical environment. So we're going to be looking at that from a data perspective to see what that looks like. But our actual approach to collecting the information is informed as much as possible by the experts that we have here in the community. Of course, I have some constraints with it being a CMS cooperative agreement, and so the set of questions are set. We have a bank of questions that have to be asked. But the way that we follow up on that and the way that we intervene on that is much more open. So we've really worked with our local partners here to think about what that might look like.
Okay, great. Unless the two of you want to say anything, I'll ask another. Go ahead.
Well, if I could just have a
Absolutely.
wee segue,
Sure.
and please feel free to pick up on this, Raquel, is that if 1 in 3 women, and this has been documented and redocumented in the United States and worldwide, is abused at least once physically or sexually by an intimate partner, has been, is being, or will be assaulted physically or sexually at least once by an intimate partner, then 1 in 3 of our healthcare providers that are asking the questions has been, is being, or will be assaulted. I think we have to look to ourselves for healing. How do we feel about this issue, disclosure, what can and cannot be done before we reach out to our clients? First, heal thyself, address, and the environment with which we work, our ceilings and our walls. How much of an atmosphere of safety, and we concerned about your safety and your social determinants and your food security and your housing do we present within this office, within this school, within this clinic, within this setting? Do we walk the walk that we talk? Thank you.
Anything?
So the only thing I would add, so as a health department, not operating like a provider in the traditional sense, we just see ourselves as, again, a convener and an entity that really helps to promote best practices. So I can't really speak to some of the specifics of what happens in that clinic setting, but we do have a role in trying to learn from the experts and get that information out. But the question about addressing sensitive situations, it brings to mind just cultural sensitivity in general. And so when we talk about social determinants of health, from a health department perspective, we do tie that very much to our work around health equity. And health equity has its roots in issues of social justice. And so when you look at some issues related to housing, related to transportation, neighborhood conditions, you can tie that back to history, and you can tie that back in many ways to laws that were created that promoted segregation. And with that also came differences in resources based on where one lives, essentially. And there are some challenges with that for providers and for all of us in public health. And so having some sensitivity to that tradition and that background that individuals bring to that clinic setting is essential. So looking at sensitivity not just on the particular health issue, but really that whole person and what they bring and the history that they represent and the neighborhoods that they're coming from. I think there's a lot of work that needs to happen in public health and in healthcare in terms of really enhancing that cultural sensitivity and competency.
Thank you. I'd really like to turn now to something a little bit more practical. So I'd like to think about the operational issues first, and then we'll circle back, and then we're going to do the financial issues. But what are the practical implications for an agency or a healthcare provider who decides that they are going to put the screening for social determinants of health into their daily routine? So give us some idea of what the practical implications are. So can we start with the operational, essentially how the day goes? You show up for work, and now we screen for social determinants of health. Chris, we got a sense of what your wife thinks about you asking her to do that. So, but how about in your clinics and whatnot, when you've kind of introduced the screening for postpartum depression, for food insecurity, for intimate partner violence, what are the practical elements that?
So that's while I may come across as a skeptic, this is really important. And the first step is there are lots of tools and frameworks to think about this. It's not like you can just sort of make up questions and say, oh, I'm going to ask about this now. So there are well thought out tools that can be implemented that can give meaningful information. The challenges are that alone is not sufficient. So many times the tools will have between 10 and 20 questions. Often they're either yes or no questions, and that they can be on a Likert scale of 1 to 5 or 1 to 3, depending upon anytime this week, anytime this month, anytime this year did this happen. So there are 3 or 4 pretty well-established tools that will screen for a variety of issues. And the challenge really for a practitioner is to make sure if we're going to start implementing this, that we're implementing it in a thoughtful manner, screening properly in the terms of sensitive to the personal information, but then also have thought through what the response for having that information is. It is going to be critical to say, if they answer this on this question, my response will be the following. If they answer this on this question, my response will be the following. So it's much like what lawyers say is never ask a question that you don't already know the answer to. Don't start screening unless you have a thought out plan for responding. And that response doesn't need to be the physician herself. It could be an office response, from the healthcare setting, a network response. And so from a practical sense, there are a number of tools that can be used, and some of them are mentioned in the reading that was included with this evening's session. So there are some very practical steps that a practitioner can use as long as they, in my mind, they have a response that at least has been thought through beforehand.
Can I turn to Raquel next, just because from an agency perspective, operationally, so you get behind this idea that social determinants of health should be now part of our conceptualization of overall health. What are the operational, because we're going to come back to the financial.
Sure. So it started really with a framework to help us really think about how do you take theory to practice. And so we developed a framework that I actually brought it here. You can't see it, but it really speaks to this cyclical nature of upstream, downstream. So really starting with upstream, what are those social inequities that have some role in how health plays out? So that could be looking at factors related to where a person lives. Again, history plays a big role, and then those sort of upstream factors do create conditions, living and working conditions, that make it easier or maybe more difficult for some to actually be healthy. That then plays out into how one behaves. So whether one would be more likely to smoke, whether one would be more likely to eat unhealthy foods or get the physical activity that they need. And then, you continue along this cycle, and then there's different points along the cycle that we feel like we can actually intervene. And so we went from this framework to actually creating a health equity policy. Within that policy, we make references to very specific policies and procedures for how we can integrate health equity into our work so that we can move more upstream and address social determinants of health. And so our procedures really lay out tools, strategies that can be applied when it comes to communications. How can we communicate better when it comes to our messages? Who are we missing? Who are we leaving out? When it comes to the data that we collect, oftentimes we collect data on race, ethnicity, or income, but not very consistent about collecting information perhaps like on veteran status. There are clearly different health outcomes when it comes to our veteran population. Gender comes to mind. We often collect a lot of information, we're not quite analyzing it. So that's some work that needs to be done. But again, there are some very concrete things we can do, whether it's communications, data, community engagement, new programs that we're developing and designing. It's really applying a health equity lens to the work that we're already doing, so it doesn't feel like yet another task that we have to do as a health department. Now, with that being said, there are some new initiatives that we feel are very necessary that will take us out of our comfort zone, but that's how we operationalize concepts in health equity so that we can do a better job of addressing social determinants of health.
Dr. McFarlane, do you want to give us an idea?
I would love to.
Okay,
I
then
really
we're going
would.
to come back to our epidemiology.
Don't forget it, please. As far as something practical for providers. Not only do I find myself with white hair in this decade, but I find myself raising a 16-year-old. And the white hair is much easier to deal with. And I got involved immediately with the 16-year-old on the parent-teachers committee at the public school in Houston that she attends. And it came up. Feeding of the children that need nutrients, that are food insecure. They'd been making a list, giving them tokens, marking off their name. And so there was comments from the floor, why don't we just give them all a banana and a taco? Would it cost us any more if we just put the bananas, the tacos out there? If you're hungry, take it. I don't care if you live in River Oaks or if you live where you live. If you're hungry, take something to eat. Well, we tried it. There was less food waste. There was no stigmatization, and it didn't cost a penny more. Sometimes I think we overthink when it comes to that word. What is practical? What is equitable? And this idea came from our student advisors. Unless we involve the people, we can sit up here until we are blue. And we are not going to have practical, decent solutions.
So I think that's a perfect segue to Dr. Highfield, in that a tenet of public health is that you should speak to and listen to the people that you seek to serve, because they frequently have ideas about their needs and preferences about how they'd like those needs to be met. So if you truly do walk the walk and try not to be paternalistic, then you should really interact with the community that you seek to serve in a respectful way and in a partnering way. So do you want to comment about some of the practical aspects?
Sure. Yeah, so really I think what you're speaking about is community-based participatory research, right? So getting the community involved, getting them with you at the table the whole way through the process, and ideally from the point of designing the question that you're going to be addressing, right? I mean, that's always the goal. For this particular question, I'm going to talk about the AHC project, the Accountable Health Communities, because I think it's a good example of thinking about practical applications around how you do screening for social determinants of health, or how you might give somebody a referral. And in that sense, there's really a few different levels of community, so to speak, right? So I'm coming at this from the outside as a public health academic, and I'm working with hospitals and physician practices and community organizations, right? So my community is really at that level, at kind of the first stage, right? Those are my key partners, those are my implementers. So I'm asking them to do something, right? And so the first thing I did was engage them. Okay, you know, here's kind of what we're doing, here's this idea, here's the project, and actually Chris is a co-investigator on the project, as are some other folks that are clinical partners. And we really talked about what this might look like and how we might be able to do this. And when we started to get into the nuts and bolts of how we're going to implement the program, we started to develop our implementation plan. And the first thing I did was go to my partners and say, okay, how are we going to implement this? These are the things that CMS says I have to do with fidelity, right? There's always some things you can't change. But there's a whole periphery around that where we have latitude to tailor. And so we have tailored an implementation plan to each site based on their particular needs and their particular workflows. And so what you see is that in some facilities, we are going to be using a kiosk, and the community health worker is going to be embedded in the emergency department and will take that kiosk into the patient room after they've been triaged. In other facilities, it doesn't look quite like that. We might actually be screening after the person has been discharged from the emergency department. So it's completely tailored to the workflow and the needs of each of the institutional partners. And the whole idea was, I don't want to disrupt patient flow, right? We have to make sure that patients move through the system in the way they need to move through the system. And you have to recognize this is more work. I'm asking my implementers to do something extra. Who has the capacity to do that in the organization? Who is the right or, quote, best person to do that in each facility? And it can look a little different for everybody. The second level of engagement is then the patients themselves, right? And getting input from the patients on the way we're going to approach screening. You know, okay, if I send you a text message to your phone, can you answer these questions? Does this work for you? Does this feel like it's not private enough? So we're not to that stage yet. That stage is coming. We've just finished the stage of developing the implementation approach at the organizational level. But that's the idea, is that you want to engage on as many fronts as possible as early in the process as you can, so that you have all thought about it and everybody's had a chance to think about what their role is. There's clarity, there's not confusion in the role, and everybody's had a chance to buy in to the process.
Thank you. So we're down to the last 20 minutes of our phenomenal session on social determinants of health. So before we get to the financial issues I'm just going to ask you to do like a speed dating kind of answer for that one. I just want to check with our audience, and I want to remind the people on the video to write a question. But so if you could bring the microphone there, and then we do have a question from the internet. So we are so technologically advanced.
I just wanted to know what the role of 211 Health and Human Services are to playing a role in this, and having navigators perhaps use that.
Yeah, so that's a great question. And kind of the approach that we have taken, so let me back up a step. So we are building our own data system for this project that's completely integrated. So when somebody completes the screening tool, their referral is automatically generated. So it can be printed and given to them in the clinical environment. That's one of the requirements of CMS, is that referral happens, gets printed, and it gets given to that person. So what we've done is we've kind of built our own custom interface, and we took all of the publicly available data for resources like 211 and have embedded that into our own data system. And what we did was we actually ended up kind of building this data set from the ground up. So we took everything that was out there that was secondarily available, publicly available, and then we started quality control, basically calling each of the organizations to see what services are you actually delivering, When are they being offered? Are they at all of these locations? So that's really a custom build at this point for us for this particular project. I know other places around the country are doing a little bit different approaches, so I think it kind of varies from site to site. There's 32 sites nationally, so we're one of 32. But for us, the process is really going to be, the goal is to have it be seamless. So you screen, you get the referral, it gets printed and handed to you, and then we do the follow-up navigation calls. And the way we're doing the follow-up navigation is also a little bit different than the other sites around the country. We're actually embedding an evidence-based intervention that we had developed in the School of Public Health related to appointment adherence, and we're adapting it for social determinants of health. And it's based on the trans-theoretical model, and the idea is if I can stage your readiness to connect and I can assess your barriers and counsel you through those barriers, then I hopefully can push your readiness to go and make that connection. So we're embedding that into our approach as well. So our navigation approach is very specific. And so all of our navigators, whether they're School of Public Health folks or at our clinical partner sites, will go through an extensive training on that.
Thank you. So you can never go wrong with the trans-theoretical model.
Right.
Just, you've heard
Works
that
for
here.
everything.
So let's hear from the internet.
So we have a question from one of our viewers. When evaluating whether an intervention is justified to receive governmental funding, how do social determinants stack up against the other factors used for decision making?
Well, okay. So let's kind of go in our typical pattern. And again, let's be somewhat succinct because we're wrapping up. Go ahead.
So I think there's very little data on social determinant screening as compared to routine care in terms of governmental policy and cost savings. I think that we're still early enough on in our understanding. The specific illnesses that often are lumped in, and I'll use, for example, postpartum depression, that clearly has a tremendous financial burden, mental health burden, societal burden, and screening versus not is clearly beneficial to the patient, and the actual dollar value of it compared to something else has not been articulated. But clearly there's value to it. It's just that we're early enough on that that's hard to know.
Good. I think I might turn to Raquel now. So you sit at the table regularly where you're thinking about screening and responding to some of these more bona fide medical problems that people would recognize. So, you know, smoke particles in the air. How does that kind of very physical type of issue that everyone says is a health issue stack up to social determinants of health?
So, I mean, just getting back to Dr. Highfield's comment about the determinants of health, I think when you look at the pieces of the pie, that in of itself justifies the need to at least try to establish more balance. Mm-hmm. Okay. Because there's so much of an overemphasis on what happens in healthcare and what can be done in the healthcare space when we know that so many factors outside of the healthcare setting are at play. So I don't think there should be, just by that figure alone, it varies between 80% to 70% when you start adding, and whether or not you're talking about population health versus all health determinants. But by a large degree, that alone I think should be rationale for at least starting to tip the scale to focus more on social determinants.
Okay. And Dr. McFarlane, not implying that you've been doing this for a lot of years.
Thank you,
but,
Dr. G. Thank you.
If you look in the rearview mirror, how do you get responded to now when you talk about some of these more socially related issues as opposed to some of the blood pressure issues? So what would you say? Has there been a change and a more receptivity, or is it kind of the same as it was a few years ago?
Oh, I think there's a greater receptivity. We're so aware, and for the first time in our history, we've got over half of us on Epic. We have got all kinds of data, and we've got people that know how to run the models. Mm-hmm. And we can put in not only whether you're employed or not, but how many dollars per hour you get at that employment. We can put in all your biologicals and your social, economic, ethnic, cultural, zip code, line of work, air quality, we can match it up and run the predictive models of what you are at highest risk for and the cost effectiveness of intervening now versus waiting. We are on the brink of a whole new upstream frontier. Healthcare is not going to look anything like it does today if we use, in 5 years, in 3 years, if we use the data we have. Do we have the political will to use that data? Is the question I ask of our esteemed audience.
Oh, we have a question.
I'm going to preface everything I say with I'm very new to the world of public health.
Welcome.
Thank you. But an observation I think is that the social determinants of health seems like a very trendy topic right now. And it also seems like people like quick fixes. But so many of the things we've discussed tonight would take years, if not decades, to materialize. So I was wondering if you have any thoughts on if this is around to stay, or if you think this might be at risk for, not capturing attention.
Okay, so Chris, is our work worth anything?
I hope so. So I agree. I think that I would reframe it as it's not trendy. It's just that it is now being better explored. So my early comments was, until about 2005, 2006, the publications for decades prior on social determinants. And so many times, just as an aside, people will use the phrase social driver because determinant gives the impression that you are baked in the cake and you're done. So we'll say social determinants because that's the phrase that people appreciate, but I think of it as a social driver, that there are these things that are meaningful. So the publications up to about 2005, 2006, until the World Health Organization exposed this, really was flat for decades. And then that happened, and I think now there's a greater appreciation that that's real. And the publication rates for the past decade have exponentially continued to increase. So it's not as if this is something that is, a chia pet or something that people are now sort of gotten soft on and they're going away. I think it's very real, and I think it has exposed another facet to the work that's being done that has been unexposed, and so that's why people are interested, because it's fertile ground.
And again, we're really short on time, so was there anything else that anybody wanted to add to that? Because I do want to ask the audience if they have any other.
Quickly, there is some real threat when it comes to changes in the Affordable Care Act. A lot of that that we're seeing now with the CMS grant, for instance, was motivated by the ACA. So there's always the potential threat of the political wind and where it blows. But I do think that there's just growing recognition. It's not now a matter of trying to convince people that social determinants is important to address in healthcare. Now it's just a matter of figuring out how best to do that.
Okay. So this session is really important for the audience, because we talk all the time. So we just said everything that we keep saying whenever we meet for coffee. So is there something are there questions among the audience that you would like to ask that you don't want to leave tonight before you, without asking? And I see Tanwir has a question, so let's get him, and then think about, and then we're going to wrap it up, because our commitment to you is that after a very long, hard day of work, that we're going to get you home.
I think most of the discussion appropriately has been a lot about screening, but I think it's good for people to hear what are some of the community initiatives that healthcare and public health have been involved with that have involved addressing social determinants of health. I think it's important because I think that's preceded and had a lot more meat going on. What are some of the community initiatives that healthcare and public health have been involved with, if you don't mind addressing?
I can take on just a couple of examples. We're seeing some collaboration across the nation where community development financial institutions are working with healthcare. So where there might be hospital systems that are seeing a high volume of individuals coming through the ER because of homelessness, for instance. We're seeing community development financial institutions provide the funding to create housing for those individuals, in addition to other social support services. So there are those partnerships between hospitals and housing, actually, building units to help individuals, meeting them where they're at. Locally, I'm seeing a lot of interest in food insecurity, a lot of partnerships being developed where it's more about incorporating produce and maybe food prescriptions as a result of a positive screen for food insecurity. We're seeing that in school-based health centers. Memorial Hermann comes to mind as one example where they're partnering with the Houston Food Bank to do this work. We're also seeing other examples of park prescriptions where providers are providing prescriptions to get people more physically active. Not sure how strong the science is on what kind of impact that's having, but those are just a few examples that come to mind.
Great. Anyone else? Because then we're going to wrap up. Oh, there's a question here, and then this will be the last question from the audience.
Dr. Highfield, this question is for you. Are you at liberty to share any information about the training curriculum that you use for the advocates that will be a part of your study?
Yes, that's a great question. We will be able to, should be able to share it later in the study. So right now we're finishing up, we're adapting a curriculum that already exists. So we're finishing that adaptation up, and then we take it to the state of Texas for certification. So because we have a public health training center, we're able to certify continuing education units for community health workers and social workers. So we'll take it through the certification process. And then once that's done, if you're interested in learning more about it, please, feel free to reach out to me. The caveat I will say is that we don't know yet how well it's going to work, right? This is a research study. So that's, one of the things that we're going to be testing is that approach. But yes, I'd be happy to provide information about that.
Okay, so as we wrap up, each of you is going to get 1 minute, and you have a magic wand, and you can do one thing with regard to social determinants of health. What would it be? And then I'm going to wrap it up, because we're getting you home by 7. So go ahead, Chris.
Okay, one thing. So the one thing that I would do is I would keep all girls in school, because I think that the data are quite clear that one of the strongest predictors for a health of a community is female education level, whether it's infant mortality. So there's a study actually that demonstrates the relationship between infant mortality in a state over the past decade, and all 50 states, except for 2, was related to the number of women in the legislature. That there's a linear relationship between women in the legislature and infant mortality in every state in America except for South Dakota and Iowa, Texas included. So, and then infant mortality internationally. Keeping girls in school will have the most positive beneficial health effect in decades and in centuries. So I would keep all girls in school if I could do one thing.
That's very clever, very good.
Yeah, that was really good.
So,
I actually was going to say education as well, but he kind of stole my thunder.
Okay.
Sorry.
So it's okay.
A better school.
Thinking about it from a different perspective, I think if I had an unlimited budget and the ability to do anything that I wanted to do around social determinants of health, I would really want to work on how we build and sustain community empowerment, how we build on assets that are already there in the community, how we use that kind of more bottom-up approach to thinking about addressing social determinant needs so that it links not just the need-based focus, but an asset-based focus, and thinks about sustainability over time, right? Which is always a challenge. How do we keep these things going? So, if I had a pot of money at the end of my rainbow, I think that's where I would go.
Okay, Raquel, how will you use your 1 minute? What are you going to do?
So I would encourage non-traditional partnerships. I think so much of health happens basically outside of healthcare, and I am biased because I wear the public health hat. But non-traditional partnerships with the legal community, transportation, housing, faith-based organizations, individuals working in early childhood development, the education sector. Just find creative ways to work with those groups.
Great, thank you. And how about you, Dr. McFarlane?
To make all of these three fine professionals' ideas happen, we've got to vote. We have to vote. We have very contentious runoffs coming up. We have before our 15 state legislatures right now to stop child brides. We cannot have any exceptions, exemptions for 12, 13, 14, 15, 16-year-olds getting married. That is what is happening in our country. 1 in 6 women that have been in an 8-year study with me reported a forced marriage. A forced marriage means rape. It means assault. It means compromising the education, the collaborative relationships, and community health. We have to vote. Social determinants of health can be a reality in the positive, but only if we allocate the resources and we vote in the polls.
Okay, thank you. So I would just say, as we wrap up, we heard some really interesting concepts about social determinants of health. We heard about some practical aspects about operationalizing that. We heard that social determinants of health are the cause of the causes. So I think that to your question, it really speaks to the fact that this is going to have some staying power, because I think the science is starting to show that social determinants of health are really kind of at the root of a lot of the issues that many of us are passionate about fixing. We also heard that screening is not an episode or a tool, but it's a process, because there's something very human and dignified about trying to partner with the patient around what's affecting their life. And I think the other thing that we heard about is that this kind of work absolutely happens in the context of engaging with your partners in the community. It's not one discipline, it's not one profession, it's not one single tool. It's really working with the people that really want to lock arms with you. But the very important thing that we heard was that you have to also connect to the patients, because the patients have views about how they're treated and how they're served. So a true tenet of public health is that you speak first to the people that you seek to serve. Thank you for your attention tonight.